You're watching the Wellness Hour, news that makes you healthier. I'm Randy Alvarez. Today's topic, what women need to know that have been diagnosed with breast cancer, and specifically if they need surgery. And with us we have a breast surgical oncologist, Dr. Laura Lee. Dr. Lee, welcome to the program.
Thank you.
Okay, so you are the one that does the surgery.
Yes.
So tell me what women need to know. And I want to bring this up, that, and I'll let you go from here, but a lot of women, I guess, have been diagnosed and they're having a board certified plastic surgeon do it because they think that's going to give them the most beautiful outcome or result. Maybe a mistake, according to some experts. So I guess it's a couple of questions. What do women need to know?
So I'm fellowship trained specifically to do breast surgical oncology. And I trained at a program where one of the big components of our program was to do oncoplastic surgery. So you sort of ask, well, what are you talking about? Well, what it amounts to is, obviously our primary goal is we've got to eradicate the cancer from the breast. But also, somewhat secondarily, but not so far behind, is to try to preserve the aesthetics in the breast. Is there a way to remove the cancer, preserve the aesthetics, so that the woman preserves her sense of self, her self-image? Even in the situation where we're doing a mastectomy, there are sometimes options available for the woman that we do something called a nipple-sparing mastectomy, where the incision is hidden, they can get immediate reconstruction, they preserve their own nipple and areola, and hopefully preserve some of their sense of self and self-worth along with having this surgery. Because it's not just the physical cutting, there is a lot of, there's a big emotional aspect to all of that.
So as a surgical oncologist, right, do you work together with the plastic surgeon if the plastic surgeon is involved? And as far as this nipple-sparing mastectomy, is that only when indicated? Or some women are saying, but the nipple area or whatever it's called may also have some of the cancer in that or attached to
A very good point. If the cancer is close to it, we shouldn't save the nipple, and I counsel the patients regarding that. There's some other things I oftentimes will ask the patient, either if they have decided they want to have a mastectomy or I've counseled them that I feel like they need it, that I try to ask them questions about what they want as the outcome at the end. Do they want to lift? Various things. Because those things all influence what we're able to do and realistically achieve in doing a reconstruction at the same time. So it's important for women to know that these techniques are out there, that it's not the same as it was maybe 15 or 20 years ago. And having surgery because you have breast cancer doesn't mean that you're going to be disfigured. And I think that's very, very important.
As a surgical oncologist, I mean, you are focused on leaving it as beautiful as possible or as aesthetically pleasing as possible. Is that the right word for it?
I want to reiterate, I'm focused on removing
the cancer first.
I also, at the same time, if at all possible, want to preserve the aesthetics of the breast as much as possible. Some women come in and tell me it doesn't matter to me, but even when they say that, I think it matters to most women.
Are the incisions getting smaller?
Sometimes the smaller isn't necessarily better.
Okay. But are they getting smaller or no?
I think in some situations, it depends where it is. I think that we're getting better at figuring out ways to achieve removing it, maybe getting a lift at the same time. But those incisions are honestly fairly large when we do that. But, you know, it's to help remove the cancer and to help the woman have the experience without as much emotional distress.
Okay, now we are going to finish this segment, but I want to make sure, because I'm not sure if we answer these questions. When women go to you and they know they're either going to have a mastectomy or a lumpectomy, what are their frequently asked questions? And I'd like you to answer them now, if you already haven't.
So they ask, where's the incision going to be? Is it going to show up? Will I be left with a divot in my breast?
We're talking about lumpectomy right now?
Right.
Okay.
And part of the oncoplastic procedure is for me to move the other surrounding breast tissue to try to maintain the contour as much as possible and to preserve the breast mound. Women are concerned where the incision is going to be because they want to know if it's going to show up in clothing.
Where is it going to be?
It depends upon where the cancer is. It somewhat depends upon whether I have to remove any skin. I try to place them so that it's not obvious, so that if the woman does not want to talk with somebody that she encounters in her day-to-day life, that she's had breast cancer, she's been treated, she's not forced to because they're staring at a scar.
Mm-hmm. Are there surgeons out there that could sit here and say, Randy, I either go in the fold or in the nipple area, or that question doesn't come up?
You have to.
Are there newer techniques where you could say we always go in the fold or we always go in that?
I always avoid using the word always, the words always or never.
Do people ever say that? Are there people that are into that? Are women under that impression? That a plastic surgeon may be more delicate to this?
Potentially. I think that they may be. The incision, just like all the other treatment, has to be individualized and for what you're trying to achieve.
All right. Okay, so I want to thank you for coming on the show.
Thank you.
And if someone has more questions and maybe they want to email you or get in touch with you, do they check with their primary care physician?
Their primary care physician have a referral, particularly someone that's been diagnosed, that if their primary care physician will refer them, that I'll be happy to see them and to go over with them what their options are.
And you must get emotional sometimes about this. I asked you in my green room that how do you detach from some of this tragedy? Are you driven by the early detection and the happy stories?
You don't always detach from it, I'll be honest and say. But I think the majority of the time I detach from it because my job for the patient is to allow them to feel whatever emotions they have, whether it's they're angry, they're frightened, they're sad, and for me to help take them through the experience and lead them so that they make the choices that are best for them.
Good. Well, thank you very much. And you feel like you were meant to do this, by the way?
I think so. It took me a little while to figure out what I was going to be when I grew up, but I eventually landed there, I think.
Good for you. Okay, so the message, early detection.
Yes.
40 years old, regardless of the 45 plus recommendations, go and get a mammogram. See if you are told you have a dense breast or whatever. And maybe take, and by the way, because there's a lot of imaging centers, should you always speak to a interventional radiation
you don't necessarily have to speak to them directly. If you're getting screening, they read those away from when you're actually physically there. If you have to have it because something has been found either on previous imaging or your physician has felt something, then they're more likely that you're going to interact with the radiologist. The important thing is that if you start at 40, they have a questionnaire that they ask you certain questions to find out about your history, your family history, and they use that information to determine what your risk is, along with them determining what the density of your breasts are, and that will inform whether you should be coming in every year or whether you can defer until you're 45.
Okay, good. Thanks again.
Okay.
Interesting stuff. You've been watching The Wellness Hour. I'm Randy Alvarez. We'll be right back.